Hello everyone, and thank you for coming to the final pitches. We are super excited to have you here today. We have a lot in store for us. Um, First off, I wanted to say thank you to all of our sponsors who really helped us make this happen, for offering your resources as well as providing mentors, as well as countless support throughout the entire process. Thank you so much. This wouldn't be possible without you. Next slide, please. Lee. Working through a little bit of technical work. Oh, here we go. All right. So I wanted to start off by saying, teams, mentors, and leads, you all did such an amazing job over the weekend, and I want to give you all a congratulations. You really worked your butts off, all the way starting from Friday night, working up until now. And so this has really been an invigorating experience, especially when tackling the problem of population health and wellness with democratizing systemic racism in healthcare. So many of you have brought creativity, passion, and expertise to the table, and it has really shown, especially in the development of your solutions. I'm so proud of you all, and this has been such a valuable experience, especially from a track lead perspective. I would welcome any of my fellow track leads in support to say a few words if you would like, just to give these folks congratulations for all their hard work. All right. So moving forward, this has been quite an exciting and eventful weekend. And I would love to introduce our judges today. So we have 4 different panelists who are going to be supplying some feedback as well as critiques to the final presentations. So first up, I would like to welcome Matt Tran, who is the Director of Product Innovation at Centene Corporation. Welcome. I'd also love to welcome Aruna Nadasan, who is a VP of Product Development and Business Intelligence at Craneware Healthcare Intelligence. Welcome to you too. Maya Hardigan, founder of CEO of Stealth Technology Startup, welcome. And Bonnie Clipper, Chief Clinical Officer at Wamby. Welcome to you all, and we're so excited to have you here to be able to provide some feedback for these participants.
Alex, would you make Aruna a co-host? It doesn't
Yes.
allow me to do it.
Sure, 1 second. There are a lot of participants in here now. All set. Next slide, please. So over the weekend, we went through the hackathon process, all starting with the introduction webinar on Friday, and immediately after we kicked off the problem pitching sessions, where we had upwards of 30 to 50 problems pitched through each track. So we were specifically track B, which was focusing on population health and wellness. So from there, teams were able to intermingle and work together to find their passion areas and really solve a many different problems through this process. So we're covering a wide variety of topics through the solutions that have been developed. And from there, we were able to guide our participants through the weekend by offering some different feedback, as well as connecting them with different mentors and resources where they can really help bring these concepts from initial idea all the way to a fully functioning prototype for some. And from there, when we had the practice pitches, we were able to offer that feedback and help these participants iterate, leading up until now where we're at the final pitch. So congratulations to you all for your hard work. We're looking forward to seeing what's going to be in store for us. But a couple of logistics first. If you could go to the next slide, please. So the judging criteria that the judges are going to be critiquing your prototypes and pitches are based on impact, innovation, implementation, and presentation. So really they're looking for, does this solution solve an ongoing or anticipated problem? Does this team provide a convincing rationale for why their solution may work? And do they address significant technical issues relevant to their problem? Implementation, could this be a proof of concept or prototype? Or is this a preliminary vision that could be executed, as well as the presentations themselves? So making sure that there's a cohesive flow and that the point gets across for each concept. Next slide, please. And so some other logistics for the presentations, this is being recorded, so this will be available afterwards. Multiple team members are allowed to present at once, but be sure to anticipate what questions are going to be asked in the Q&A. You will have 3 minutes and nothing else more. We will cut you off at the 3-minute mark just to keep on time since we are in a packed schedule. Mentors and judges, judges will have 2 minutes for Q&A, and that's in total, so not 2 minutes each. So the order of presentations is also completely randomized, but we will let you know when you are up next and on deck, so that gives you a few minutes to prepare. If you will be presenting for your team, can you please use the raise hand function, which can be found under the participants panel. And so if it is your turn to speak, once you raise your hand, we can unmute you and you can begin presenting. I'm going to be holding up a timer throughout the presentation, so try to keep an eye on me. So you're going to have 3 minutes, and then I will also be timing the Q&A too, but you will hear when the alarm goes off. And finally, the judges will be picking 3 winners for the track, and so we are most excited to see what that may be, but the deliberations will happen after this as well as the awards ceremony. Next slide, please. So going over again, raise your hand, please, when it is your turn to speak. Judges can unmute themselves, of course. And so we will give you the opportunity to unmute when it is your turn. You will have 3 minutes to present and 2 minutes for Q&A. And with that, we will go into our first team. So I would like to welcome to the table team B22, which is Be My Voice. You are going to be our first presenter, and after them, we have team B15, which is Gia Care. So Be My Voice. If you could please raise your hands.
Hi, am I audible? I cannot hear you, Alex.
We can
Whenever
hear you.
You're ready, I'll start the timer. Sorry, I was on mute.
Luciana, you're muted.
I think it's Yini who's presenting.
Oh.
Hi.
Hi.
Can you hear? Should I have the video on or off is okay?
That's up to you.
Okay. All right, I will get started. Hello, everyone. Today we will pitch a mobile app idea, Be My Voice. Next. Racial ethnic disparities in healthcare is a huge, costly problem. Next. One key factor driving these costs is underutilization of primary care services, which would be 5 times cheaper than the emergency department. Next. If the Black population had preventable hospitalizations at the rate of their white counterparts, this alone would save the US $3.4 billion in healthcare spending. Next. Underutilization of primary care is influenced by physician distrust, resulting in failure to adhere to a treatment plan. Next. Research studies have confirmed that medical distrust explains the difference in Black-white primary care utilization. Next. Therefore, we present a solution to address medical distrust. Next. The concept is to connect patients to medical volunteers on a virtual platform to be present as social support in the clinician's office. Next. We first demonstrate what the app would look like for a patient. Next. Where you indicate your needs and your race, ethnicity, background. Next. And then you indicate your appointment time or whether you need on-demand support. Next. And we demonstrate what it would look like for a medical volunteer. Next. Where you indicate your credentials or a form of training would be provided to make you available as a medical volunteer, as well as indicating your race, ethnicity. Next. And then you can set your availability, whether on demand or certain available time slots. Next. We envision there are 3 major stakeholders. Next. And we would operate within the mHealth landscape where we touch on an underutilized area addressing social determinants to to promote healthcare disparities right at the point of patient care, helping patients get through the door. Next. For each of the three stakeholders, we envision the following for value creation, where primarily for the patient, we address distress by the presence of social support to overcome the issues that distress presents. For medical volunteers, we introduce culturally competent care training, focus on altruism without the geographic boundaries of traditional volunteering. And for investors, we primarily believe that this would help reduce health and economic costs, address systemic racism through social determinants, and provide access to minority populations at an unprecedented level. Next. We define our implementation timeline as follows. Next. Last but not least, I introduce our team members and mentors who have been amazing this whole weekend.
Right, that is your time.
Oh, well, thank you very much.
Now we will open it up to judges to allow for some feedback.
Hey everybody, this is Matt. Question for you. I see your solution as app-based. Oh, and again, thank you for presenting. Appreciate you taking the time. I see your solution as app-based. How do you address those who would not have access to a smartphone or an app-based type of solution?
Yes, that is an important consideration. Certainly, this is targeting those who would have a smartphone available. The concept sort of expands into the potential stakeholders or collaborators, which could be the device providers or hospital systems that want to engage with patients better. So hopefully partnerships through hospitals or device providers suggest there's value in reducing the racial ethnic disparities, or provide a market for which they could expand on. And overall, there is a broad accessibility for people with mobile devices. So primarily, we would target those who already have devices, and hopefully we could provide a purpose to expand medical coverage for those who currently don't have cell phone devices, so that this could be a purpose-driven model.
Hi, it's Maya. A quick question. So I can definitely appreciate the value that this solution brings from the perspective of advocacy and having a culturally competent care advocate by an individual's side when they attend a primary care visit. I'm curious to know how you're thinking about addressing the broader problem you raised at the start of getting people into that primary care funnel in the first place.
Thank you. So I guess the focus of this app at the present was to reduce the inhibition in going into a clinician's office without the knowledge or equal access to the information in the healthcare space. Of course, there's broader problems of, well, if a person never accesses this space, how do we contribute the discussion to make it more feasible? So for now, the goal is—
That is it for our time.
Sorry.
It is okay. Thank you very much.
Thank you.
Up next, we have Team B15, which is GeoCare.
Hey, Alex, sorry, can you go back to the previous slide?
We'll give the judges a moment to
just go back to the, remind them of the team number.
Yeah, thank you so much.
Yeah, so that was Team B22. So Team B_02022.
Judges, when you're ready, please let us know so we can proceed.
I'm ready, thanks.
I'm ready, thank you.
Ready. I'm ready, thank you so much.
All right, thank you, judges. So up next, we have GeoCare, which is team _B_015. And then after them, we have team B_002, which is Dietary Champions. So whenever you're ready, please feel free to start.
Am I audible?
Yes.
Hello. Okay, I'm gonna start. Hello, everyone. We're GeoCare, Team 15. We're here to digitize maternal care for women of color. Next, please. Maternal death rate of Black women is 3 times higher than white women. Not only are patients at risk, but maternal death also puts physicians at risk for medical malpractice lawsuits. And 67 of these deaths can be avoided through preventive care. 30% of deaths are caused by wrong selection and management of therapy. Next. After talking with a mentor from the African American community, who is also a mother, we found these target points: lack of easy and properly communication with medical provider during pregnancy, lack of access to volunteer services, and the need for advocacy for minority pregnant community. Next. Our solution is an app that records health history and analyzes this health data collected from open source smart devices and send report and alert to medical providers. Start from the pregnant women, we also built up a volunteer community as well as to educate the pregnant women about their medical complications. GeoCare sells the data solution to existing medical information systems such as Epic and Cerner, so that we integrate the risk score analysis and risk factor report to every hospital's current work process. Thus, our solution is financially sustainable and totally free to the pregnant women. Next, this is our this is our UX prototype. We collect heart rate, fall detection, temperature, domestic violence, and mental health situation. Next, GeoCare will detect any abnormal health signals and initiate medical providers' intervention. Any domestic violence and mental health alerts will be sent to GeoCare community portal so local volunteers can offer drop-in care and counseling. Next. Our primary customer group are the 14 million African American women who have access to smartphones, with the potential to be scaled up to 20 million through our web app. Next, GeoCare's value proposition is that with better quality of treatment from medical providers, offer educational videos and services for pregnant women, and empowering pregnant women of color community by building trust and connection between pregnant women, medical providers, and related organizations. Next. This is our predicted timeline. We plan to deploy the mobile application by April. Next. This is our market analysis. Apart from our competitor, we are providing automatic whole process tracking and properly midwife support. Next. This is our business model. Besides revenue from medical information system, we also have potential revenue from advertisements and premium package services as our users group grow. Next. Please allow me to give a big shout out to my wonderful team who have worked so hard. We have more information in the appendix, and we're now ready for your questions. Thank you.
Thank you very much, GeoCare. All right, I would like to open it up to the judges for feedback.
Question, that was a great pitch. I want to understand what's your rollout strategy for the app?
The growth strategy, did you say?
The rollout strategy.
Could you elaborate on the question?
Rollout means what's your model to get this app in the hands of the patients?
I see. So firstly, our smart app, our smart devices will be provided for free if the pregnant woman already have connections or have a fixed a medical provider or with a relationship with their insurance. So if they have this smart device, they will be taught how to upload this data into our backend to use our app. And for women who don't have this kind of apps, this kind of the fixed relationship with their medical providers or insurance, our app will be we will send out like advertisements advertisements and promotions for them to download our app just for educational services. And we are also allowing them to buy the smart device at a very low price because we are funding them through the money we're earning by selling this data to the medical information systems. So from these two ends, I hope we can get as much users as involved as possible. Thank you.
So you're not relying on the payer to fund these devices, but you will be, you as a company will be funding the devices through the revenue and investment.
Yes, that's correct.
Thank you.
It will be totally free. Any other question? If not, I can use like
Hey, this is Bonnie. I have a question for you. Have you thought about how you're going to get the app in people's hands before they're actually a patient or into the health system?
Yes, that's an excellent question. So before they are in the health system, but as long as they find themselves pregnant, we plan to send like advertisements on a clinic store and pharmacy for them to download our app for further information.
Thank you very much. Judges, if you could please fill out your sheets.
Thank you, mentors. Thank you, my team.
Hack team B, we have this being recorded, yes?
Yes.
Thank you. I'll confirm on the other channel.
I'm ready.
Thank you.
I'm ready, Alex, as well. Thanks.
Ready.
All right. I think we are all ready to go.
Yep, I'm ready to.
All right. Up next, we have Dietary Champions, which is team _B_002. So I see Olga has raised her hand. Coming up after Dietary Champions is team _B_042, which is Go Forward Humanity, Global Health and Wellness. So Olga, whenever you are ready, please feel free to go.
I'm ready. Our team is focusing on integrating nutrition within primary care. Next. Primary care physicians value nutrition, but they are not aware of their patients' nutritional needs and actually their living arrangements. We're proposing integrating a screening tool into well primary care visits, and based on needs and intervention that's provided to older adults with food insecurities at the PCP level. Next. In my experience as a community nurse, I have encountered multiple patients like Isidro Jose Rodriguez, a Spanish-speaking 68-year-old male who has difficult time understanding English and feels embarrassed when encountering multiple people when managing his basic nutritional and medical needs. He holds Medicare and MassHealth for his insurance, has multiple comorbid conditions, and lives alone in an affordable housing apartment in rural Massachusetts. According to the US Census, 17% of mass population are 65 and older, and 1,900 and 3,000 hold Medicare and Medicaid as their insurance. Next. The screening tool starting the conversations will consist out of 8 questions and would be embedded in Epic EHR. It will assess nutritional status of older adults and could be administered by a medical assistant after taking Isidro's vital signs at the next PCP visit. Next. At the next visit, Isidro will complete the nutritional screener, and the results would reveal that Isidro can't afford nutritious foods that will align with his chronic conditions. He will be at the point of the visit referred to Meals on Wheels in his neighborhood, and that will take just 1 click in Epic EHR. That will avoid fragmentation of services and will ensure continuity of care, all within primary care. Next. Upon arrival home, Isidro will receive a call from his local Latino Meals on Wheels company and will be encountering only one person, which will avoid his dreading encounter of many people and talking about his food insecurities, particularly in the language that he doesn't understand well, which is English. Next. As a snapshot, we offer embedding the nutritional screening within Epic Electronic Health System, then establishing the nutritious baseline, and based on the results, if they are alarming, then we'll offer an intervention that is culturally sensitive, which is Meals on Wheels delivered to Isidro's house and paid by Medicare, Medicaid. And also we'll collect the feedback from all stakeholders. Next. Why is this important? First of all, we gather baseline nutritional data of older adults. I incorporate that into EHR.
That is your time, Olga. So now we will open it up to some questions and feedback from the judges.
I have a question, great idea. Unfortunately, we couldn't see it all the way through, but the question maybe you have an opportunity to answer now is like, how would you convince Medicaid to pay for Meals on Wheels? How would you run that partnership or the synergy to happen?
We are, Meals on Wheels are offered in Massachusetts, and Mass Health is paying for it for older and frail adults. So Meals on Wheels is an existing program already, except the referral is not provided at the PCP office. It's usually people having home care visits are referred by case managers or registered nurses to Meals on Wheels. And that creates a lot of paperwork and red tape. And our proposition is to avoid the red tape and make those nutritional interventions happen at the primary care, which will save time and also build a trusting therapeutic relationship between the PCP and the patient.
Thank you.
Hi, it's Maya. One point of feedback here is that I think I think that this is a phenomenal idea and exactly what we should be doing. And I think the challenge, the real world challenge of something like this today is that many of our healthcare providers are not compensated based on outcomes. They are compensated for treatment, right? And so one point of guidance here would be to think very deeply around customers who do hold a lot of the financial burden for care outcomes, right? Health systems that do also own their own and operate their own insurance arms, like Kaiser, for example, because they will have more of a stake in longer term outcomes for their body of patients.
PCPs can be reimbursed for nutritional screening, and they can bill Medicaid and Medicare, both.
Okay. Who is paying for this?
We are targeting low-income population who hold Medicare and Medicaid, but can be actually applied to any insurance. Even private insurances pay for nutritional screening.
That is your time. Thank you very much. We'll let the judges wrap up with their forms.
Judges, this was Team B002. Please let us know when you're ready.
I'm ready, Alex. Thanks.
Ready.
Yeah, ready.
All right.
Good, thank you.
Awesome. So up next, we have team _B_042, which is Go Forward Humanity, Global Health and Wellness. And coming up after them is team _B_021, which is Navigate Wellness. So Catherine, you have the floor.
Okay, I'm ready. Can you hear me?
Yes.
Great, sorry. So this is Go Forward Humanity, Global Health and Wellness Platform. Next slide. So the backstory here is a Black man diagnosed with lung cancer in the time of a pandemic.
Catherine, you're on mute.
So the backstory here is a Black man diagnosed with lung cancer in the time of a pandemic. Over the last year, my dad has had multiple episodes of pneumonia, worsening cough, urgent care visits, primary care appointments, and hospitalizations. But it wasn't until July when shortness of breath on walking and wheezing led to 4 negative COVID tests before a lung cancer diagnosis set in his new fears that we see in the research that shows that health disparities for Black men are worse than US white men and men in Bangladesh. Next slide. What is the problem? The problem is silence and fear delay early detection, diagnosis, treatment, and support. Pain is a teachable moment of opportunity among vulnerable patients. Next slide. Right now, I am a portal. I am an app for my folks offering clinical expertise, psychosocial support, advocacy, and navigation, even some coaching. But I know a larger community needs life-saving help too. Platforms already exist, but they are out of reach and disconnected for those struggling. Next slide. So we have a prototype that's already established. It's called Health Army, and it's centered around robust volunteer multilingual expertise, offering evidence-based materials and resources, strategic partners within science and medicine, and a global patient reach. We feel like patients feel like they're alone, but they can conceive their illness beyond even their community and around, connect with folk around the world. Next slide. We see stakeholders and investors as already existing. There are a long history of respiratory illness in the world. So places like the Better Breathers Club from the Lung Association and a longevity app, we could very easily push this into those platforms and use places like the American Thoracic Society's research and even more of what is designed for patients to be a prevention app, using things like Calm, because in this time we all need to be breathing a little bit easier. Next slide. So this is our team. We are from Peru, Mexico, New York City. If I have a second, we'd like to acknowledge, next slide.
All right, so that is your time. Thank you very much. I'd like to open it up to some feedback.
So is the solution a device or is it an app? Like, I'm not sure I
Solution
follow.
is a platform that can be through an app. We also think of vulnerable populations as not necessarily smartphone savvy. So it could be in a kiosk, in not only a medical center, but even in a library. But it's the platform that creates connection, both to information and to clinicians and to each other.
So does it include the content then?
It includes the content.
Thank you.
And a quick question from me, it's Maya. How would you describe the differentiation of this from the many educational resources that already exist for patients
So
on the web?
So the Medical Army app, can I go back in the slides? I don't know if I'm allowed. Okay, but the Medical Army app already exists, and it has a robust community of clinicians that are available to guide people with expertise, because patients need expertise beyond the clinical encounter.
Mm-hmm.
It's ongoing complexity to manage.
Okay. Thanks.
And it's patient to patient connection, the feeling that I'm not alone in a global community, getting people out of silos to be able to see themselves. If you have Mexican heritage, to see a Mexican person in your community also battling, to know folks that are journeying with you.
And how will you continue to keep the flow of volunteers steady and strong?
So we find that people who know this business know that there's a need, and people are generally, we have there are over 100 clinicians already in this app, and we believe that just gentle outreach, that reaching out to even like pulmonologists and offering them the app so that they can send it via SMS to a patient, but then also asking them, could you join us for an hour each day or 20 minutes?
Thank you
Like
very
that.
much.
Mhm.
Let the judges fill out their forms.
Judges, this was team 042, B042. Please let us know when you're ready.
I'm ready.
Alex, can you check the settings when I'm admitting people from the waiting room? Their videos are coming on and I'm having to manually turn them off. Thank you.
I'm ready.
I'm ready, Alex. Thanks.
I'm ready as well.
Thank you all. All right, up next we have Team Navigate Wellness, which is Team B21. So I'd like to welcome you. I see we have our speaker ready. And coming up after them is Team B01, which is CareMap. So whenever you're ready, Chi-Chi. Are you there?
Can you hear me?
Yes.
Okay, I can't see the presentation. Oh, okay, I can see it now. Okay, I'm ready.
Okay.
Greetings, everyone. We present to you the Wellness Illuminated app. Next, please. In 2019, 7 million Black Americans reported having a mental illness. The problem is that 33% of these Black adults who need care don't get it. Next, please. That's why we've developed a digital healthcare tool that screens users and provides gamified self-help resources that are culturally and linguistically tailored to address common mental disorders such as anxiety and depression. Next, please. Here's Anaya, our potential user. Based on past experiences with the provider who lacks understanding of her cultural background and the stigma around mental health in her community, she's hesitant to meet in person with the clinical provider. When she logs into the app, she completes an assessment that has been tailored by a team of diverse mental health practitioners for Black users. The results of that assessment create an individualized plan for Anaya. Next, please. Her individualized plan included evidence-based, culturally tailored, gamified self-help resources, videos, meditations, and more. Our user is not only internally motivated by the desire to feel better, but also by the external reinforcement of the rewards and health challenges. Many of the resources will be made available offline for those who don't have steady access to internet. Anaya can tap into peer networks on the app, and if she needs it, the app will provide referrals to providers and alternative therapies like yoga that fit her particular culture, language, and insurance situation. Next, please. We will offer a freemium model to our user where they will have immediate access to assessments and pre-recorded videos for free. Of the 7 million Black Americans with a mental health condition, 0.01% of our total addressable market is 70,000 users. If only 10% of those 70,000 users subscribe to our platform, we will generate an annual revenue of at least $420,000. Additional income will come from our strategic partnerships with universities, insurance companies, government agencies, and more. Next, please. What our two competitors in the market fail to do is provide both culturally tailored self-help tools and direct linkage to mental health professionals. That's the value that we bring to the table. Next, please. We have a passionate team with a diverse set of skills, cultural backgrounds, and experiences. Next, please. We hope that you will pick Wellness Illuminated now for the win. Thank you.
All right, thank you very much. I would like to open it up to some questions and feedback.
So how would you deploy this to a population that doesn't have smartphones?
Sure. So the idea is that for those who don't have smartphones, they would be able to access all of the tools, the resources, etc., via website. So there will be that duality to be able to, regardless of whether you have a smartphone or not, to access your results, your data, everything via website.
Thank you.
How do you think?
Go ahead. Go ahead.
How do you think you begin to create the uptake and start to grow some green shoots as it pertains to the freemium model concept?
Great question. Thank you. So just given access to the current networks that we have, we plan to, of course, engage. There are many influencers within the Black community that really, truly are proactively trying to get members of the Black community to be more proactive about self-care and mental health care. So we would collaborate with them. We would seek out early stage venture capital funds investing in these B2B technology companies, and the idea is that they would already be connected to corporate partners and have a robust full-time growth team to help us conduct the research and design activities to refine this app.
So how are you going to build the app? Do you have a prototype? I mean, I was looking at your team composition and it wasn't clear to me.
Yes, we have consultants, UX and UI consultants. We have conducted several design workshops with the UX and UI consultants, and we received so much feedback, and we further refined our app based on that feedback.
All right, that is all the time we have. Thank you very much.
Thank you.
Let the judges finish up.
Judges, this was team B021. Please let us know when you're ready.
I'm ready.
I'm ready as well. Thanks.
Ready.
I'm ready to, thanks.
All right, thank you all. So now we are moving into team B1, which is CareMap. And then upcoming, we have team B24, which is Tiny Clinic. So I'll let Erica take it away when she's ready.
Great, thank you so much, everyone. CareMap is the socially and culturally relevant digital navigator that shepherds patients without intensive medical needs through a new diagnosis of diabetes. Next. Racism is a public health crisis. Diabetes is a public health crisis. And 8.7 million Black and Latinx patients find themselves at the intersection of these two life-threatening conditions. 1 in 4 healthcare dollars goes to treat people with diabetes, an estimated $327 billion per year. And poorly treated diabetes leads to vision loss, kidney failure, amputations of the legs and feet, and death. For our customers, integrated healthcare systems, this has impact in 3 key areas. For the health system, there is lost revenue. On the payer side, there are significantly increased costs for hospital admissions and complications for uncontrolled diabetes. And as an employer, there's reduced productivity due to poor management of disease. Next. But there's hope. One-on-one patient navigation works. Multiple studies have demonstrated improved patient outcomes, lower costs, fewer hospital stays, and most critically, improved patient treatment satisfaction. This final one to us is an important measure of improved trust. However, this is a resource-intensive service that can't reach all patients and all needs. Navigation needs to scale and be personally relevant to each patient starting on this challenging healthcare journey. Next. Our solution for integrated healthcare systems and their patients is individualized digital navigation, informed by you. Providing cultural, competent, and equitable care requires time and resources that physicians and their staffs don't have. CareMap assesses each patient's beliefs, attitudes, culture, language ability and health literacy, socioeconomic status, barriers to accessing care, and social support. Next. It then provides a map for each patient's journey, customized with information and resources specific to their medical and socioeconomic needs in a culturally relevant way, which is not available in existing diabetes support tools. We aggregate all of the various care needs into one simple plan and schedule, and CareMap adds another critical component. Patients will have access to chat with people who've gone through peer-to-peer training so that they can connect with people like them, people with the same background. It's time for health systems to step up and fight the disparities that have been building for so long. By purchasing CareMap, integrated health systems will realize savings across the organization, and by providing it to their patients at no cost, they'll improve patient outcomes in their underserved communities. Next. The CareMap has a vision to pilot our solution with an integrated healthcare system partner informed by patient, community, and health system feedback within the next year. Next. We are powered by clinicians, software engineers, and designers. We are passionate about creating equitable care in diabetes management.
Right on time. Thank you very much. Now we'll open it up to some questions and feedback.
Fantastic.
So this is Aruna, Erica. I mean, you started off with diabetes management as a problem statement, but then you moved into a solution which to me sounded like was broader than diabetes itself. So I'm kind of help me understand, like, how are you connecting the problem, specific problem of diabetes management to this solution that you had proposed?
Sure. So CareMap would be provided to newly diagnosed patients within an integrated healthcare system who were not good candidates for one-on-one traditional navigation. And they might be, reasons to not use the app would be either lack of access to the digital services or because medically they're too complex to rely solely on a digital device. And then that device will walk them through all of the next steps in their care plan.
Okay, so the care plan goes beyond diabetes.
The care plan is specific to diabetes, but because diabetes is a complex disorder with multiple different specialists, interventions, and appointments, the CareMap helps to aggregate all of those for the patient, and then also provide specific resources that are driven by their own personal needs.
Okay, thank you.
But I will mention, if it's successful in diabetes, there are many other places that can benefit from patient navigation. Oncology is a very robust field in one-on-one navigation. And so we expect that if this were successful with diabetes, we could also address similar challenges in other areas.
Yeah, thank you.
It's Maya. A quick question. I would like to know and understand why you opted to have health systems be the payer for this solution versus insurance companies.
Yeah, so integrated health systems were the first approach for reasons that were mentioned before, like Kaiser. They not only recognize value on the health system side, but also on the payer and employer side, since most of their employees have their insurance.
Mm-hmm. Agreed. Yeah. So health systems with their own insurance arm. Perfect.
Exactly. Yeah. Yeah.
Yeah, I agree. That's a great question, Maya.
All right. That is all the time we have. Thank you very much.
Thank you all.
All right, we'll give the judges a moment to fill out their forms.
Judges, this was team 001. Please let us know when you're ready.
I'm ready.
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 I'm good. Thank you.
All right. Up next, we have Team B24, which is Tiny Clinic. And then coming up after them is Team B4, which is Easy Periods. So whenever you're ready, Tiny Clinic, take it away.
I believe Natalie, who's presenting, isn't unmuted.
Is it Natalie Shager?
They haven't raised their hand.
Am I here? Can everyone hear me?
Yes.
All right. Our hack is healthy hair, healthy heart. Next slide. Heart attack and stroke are leading causes of mortality in the United States. Hypertension increases risk of these diseases. More than half of Black adults in America have hypertension, and fewer than a quarter of this population receives treatment. Heart attack and stroke are preventable diseases, but people need consistent access to health resources to be aware of the problem. How can we help the public manage hypertension to save lives? Next slide. Keeping these statistics in mind, the population we aim to serve are the adult African American men and women in medically underserved low-income communities. Our team has one Chicagoan and one ex-Chicagoan, so we chose Inglewood, a neighborhood in Southside Chicago, as our prototype community. We will offer hypertension care services, including blood pressure screening, diagnosis, lifestyle education on diet, exercise, smoking and alcohol use, and medical management. Next slide. Healthy Hair, Healthy Heart brings the hospital to local salons and barbershops. We do so by connecting health systems and payers to community partners to establish more accessible types of care. Next slide.
So why our solution? So we'd like to, first of all, we'd like to utilize the community research, which is barbershops and hair salons, to bridge the disparity in healthcare. Also, people tend to do their hair once every 3 to 4 weeks, and so we would like to frequently monitor their blood pressure. Additionally, we'd also like to capitalize on unused commodities such as wait time and empty space to be financially efficient. We can also create incentives for people to come back through rewards programs. And also, we'd like to extend the evidence-based practice that we have. Currently, we have a lot of studies for Black men, and we'd like to extend those to Black women. Next, please. So what value do we bring? So we have 4 main stakeholders. The first is patients. We are going to improve the health outcomes and quality of life for patients while reducing their mortality. Also for the hair salons and for the barbershops, we're increasing foot traffic and volume, which would increase their revenues. Regarding the states and insurance companies, we're decreasing their overall healthcare costs. And for the health systems, we're reducing the readmission rates and ER visits. That information is public, and so that can enhance their overall image. Next slide, please. So regarding our next steps, what we want to do first is we want to negotiate agreements with payers and insurance companies based on these incentive programs that they have. Then we want to partner with barbershops and salons in the Englewood area. Afterwards, we want to partner with a local health system in that area to offer our services through. Then we want to launch a marketing campaign to increase awareness. Then we want to expand our program to other neighborhoods in Chicago and then to maybe other cities in the United States. And then finally, we want to create a platform that can facilitate these community partnerships. Next slide. So this is our team. We're a very diverse team across the United States, and we come from very diverse backgrounds. And with that, we'd like to conclude our presentation and open it up for questions. Also, I'm unable to open my camera. I would love to open it if it's possible.
Let me see, but we will
awesome.
Open the judges.
How do you guys manage privacy in the shop, like patient privacy?
Yeah, I think that's a very good question, and I think the way that we're going to do it is they're going to do the test, and then the results are given privately through through a paper. They don't have to be vocally given out.
It's a great question, and this has been done before, and it didn't come up as a problem, so we can reach out to the groups that have done it before and see how they managed their exact privacy solutions.
I'm curious, when you think about being able to, I'm thinking about the cost burden of placing kiosks, right? And whether there would be a positive ROI on placing kiosks in a hair salon versus placing kiosks, for example, in a community grocery store, convenience store, somewhere where you could justify that cost because there will be higher traffic. Curious to know why you landed where you did.
We started with barbershops because it's a way to reach out to African American men. It's sort of a social hub for a lot of communities, and decided to also expand to salons so that we would have a mix of both men and women, people that wouldn't be going to the exact same locations.
Yeah, I'd also like to add that we're not going to be using kiosks, but actually rather people from our providers, our healthcare providers, just to come and help us. So it's not going to be kiosks, it's going to be actual people.
Yeah, just in that regard, I mean, there's a cost for the shops. I mean, our actual real estate space. So somebody sitting in there or setting up a little kind of mini clinic or even curtain can take up space in a shop.
That is all the time we have. Thank you very much, team. I'll let the judges take a minute to fill out their forms.
Judges, this was team B024. Please let us know when you're ready.
Ready.
I'm ready, thanks.
I'm ready, thanks.
Ready.
Wonderful. All right, up next we have team B4, which is easy periods. And coming up after them, we have team B18, which is enhance. So Tanir, take it away whenever you're ready.
Okay, do I have to start my video? Because I might face some lag.
If there's gonna be lag, you don't have to start it.
Yeah, thank you. Fine, I'm ready to start. I'm starting? Yeah. Okay, I'll be conducting the presentation for team B004. Next slide, please. Meet Polly. She's a 23-year-old girl living in the city of Detroit, and in her location, the net connection is not that great. Her income category can be categorized as falling under the category of low median income level. She has no substantial inherited wealth, unlike most of the privileged population. The present slashing of salaries due to the ongoing pandemic has made it extremely difficult for her to access and afford sanitary equipments for menstrual health management, for example, like tampons and sanitary napkins. And therefore, this has driven her into period poverty, and she has fallen a victim to it. And this is not just the story of Polly. This is the story of 1 in every 4 women in US today who suffers from period poverty, which approximately estimates to 42 million people. The primary reason for this is inaccessibility and inaffordability. And this is the problem that we want to solve. Next slide, please. Next slide. Okay, so we present you with easyperiods.com. So we are a door-to-door assistance service who delivers menstrual care. The other slide, please. I didn't say next slide. The slide before, please. The second slide. Okay. The second slide. This is the first slide. I mean, the slide after this. Yeah. So we are a door-to-door period essential delivery system. We are eliminating menstrual poverty by making period essentials accessible and affordable through better supply chain network and by creating fund pools to support menstrual health management among marginalized community. Our solution can be used by people who have both great net connection and also who don't have great net connection. They can connect with us through toll-free numbers. The next slide, please. Okay, our business model. So our customer base is the entire menstruating population of US, but we have divided the entire population into 2 parts. One is the privileged population and the underprivileged population. For the privileged population, we're going to make our solution available to them in 2 ways. One is a buy and pay way, and the other one is a subscription pay. In the subscription pay model, they not only get access to kits, they not only get to buy kits, but they also get courses and counseling for MHM. And it is to this population that we invite to donate for every purchase that they make. And with the help of this donation fund pool, along with collaborations with several NGOs, we go on to provide kits and MHM counseling to the unprivileged menstruating population. Next slide, please. Next slide, please. Okay, yeah. The marketing slide. The slide before. Yeah. So our marketing models, we are going to hire women. So how we are going to market it, we are going to hire women from the same community. We're going to tie up with hospitals, schools, corporates, and churches. We are also going to advocate strongly for tax redemption on sanitary napkins. We are going to host different campaigns in the form of exhibitions in order to raise funding, and we will use social media marketing extensively. Thank you. Next.
That is your time, and we'll open it up to some questions from the judges.
Thank you so much. We are open to taking questions.
Hi, it's Maya. One question that this brings to mind, I wonder if there's a measurable economic impact of this problem that you could use to justify funding from businesses, because I think that could have a lot of potential to impact your ability to reach more women.
Sure. So one of the ways we are doing is like our main target population is, of course, the underprivileged people who are struggling with period poverty. To support them, we are actually keeping this model where the privileged population can just use our service as an Amazon service. We are just an Amazon service just for menstrual health equipment. So they just can order their equipments. And we are providing this all the products at a very cheap rate because of the supply chain that we are trying to build, or that we have built. We're basically going to build a supply chain that directly connects us to the manufacturer. And for these, we have chosen two countries. One is Vietnam and the other one is China. So we are going to import those, and those are going to come to us. And from there, we can actually make those available at a very affordable rate. To give you an example, we have estimated that at 3.5, so somewhere between 3.5 to 4, we can make menstrual cups available to any population, irrespective of the economic class of it. Any population, we can make the menstrual cups, which are available at $10 or $20. We can make them available to the customer at rates between 3.5 to 4 if we are really sourcing from countries like Vietnam and China.
Hi, Tanir. This is Aruna. I have a question. Like, most of the privileged community are very brand oriented and brand loyal. How would you convince them to move away from the brand to a product that is built outside of United States?
So there are two things over there. So for example, we are only going to connect to manufacturers who are FDA approved. We are not going to connect to any manufacturer that is there. So we're only going to connect to FDA approved manufacturers. That's the first thing. Also, we are keeping the domestic supply chain service open in case somebody says that I only want it from this particular brand. So we are also keeping the door open for domestic supply chain too. Yeah.
Thank you. That is your time. We'll give the judges a moment to wrap up their sheets.
I'm ready, Alex.
This was team 004.
Ready, Freddie.
Ready.
I'm ready, thank you.
All right. So up next, we have team B18, which is Enhance. And then coming up after them is team B26, which is Health Now. So team Enhance, whenever you're ready, feel free to take it away.
Ooh.
Hi everyone, we are Enhance, and the problem that we are trying to tackle is racism in the healthcare industry. Next slide.
For the past few centuries, racism has been a big factor into healthcare, and that impact is only growing. Our approach to treating and providing care to people often changes between different races, genders, or age groups. Doctors make assumptions on people based on their name or race, and this is bad for many families of color. Next slide. Around 24% of Black patients get poor care quality from their doctor. With that, around 21% spend little time with their doctor. When comparing this to white people, around 9% of them get poor quality and around 10% spend little time with their doctors. Next slide.
Here we have an example of an African-American high schooler named Michaela Robinson. Michaela's mom starts calling their local doctor's office to find appointments for her mom's flu. She didn't get any luck finding doctors online, so she went to the doctor's office in person and tried to schedule an appointment. But little did she know the doctor rejected offers based on several factors. One factor was because they looked like they lived in poverty, and also because of their dark-colored skin.
I don't think you unmuted.
This is where Enhance comes in. Next slide. Enhance is an app that helps people schedule appointments. In this app, the user is anonymous. Next slide. This patient wouldn't mention their race and only mention the main aspects. Because of this, the doctor won't be able to choose between different races. When registering, the patient will not need to enter any financial information because that is one of the reasons why people of color are receiving poor care. To replace the name, the patient would be a number like 001. We made the name numbers because the doctor will most likely be able to tell the race based on the last name. In the app, most of the appointments will be online except if the patient is in patient. Next slide. Our company's funding is based on ads and investors. Our app is not going to be handling any of the money because we are going to be the middleman. With this, we won't need to deal with insurance, but we will be taking an 8% cut from the money that the patient is paying. Next slide. We have many competitors. There's one competitor called Teladoc. Teladoc is a telemedicine company that gives medicine to patients using technology. Their app does kind of the same things we do, but we have many advantages as shown on the slide. Next slide.
We have created a layout of what our app is going to look like. During the registration process, the user would input the important information like age, height, and weight. Next slide. Once the user has signed up, they will be taken to their homepage where they can either request a doctor's appointment or they can enter HAQ. If the user wants to schedule an appointment on their home screen, there will be a request button where they can schedule a time where they can attend an appointment. Next slide. On the doctor's homepage, there will be a notification that pops up asking if the doctor can accept the patient's request for an appointment. If the doctor does accept the appointment, the patient has 48 hours to pay through the app. Once that is done, the doctor will not be able to cancel the appointment, and the patient will send the rest of their info, such as past problems with their body, diseases, allergies, and why they need the doctor at the time.
All right, thank you, team. That is your time. So we'll open it up to some questions and feedback.
Hi, this is Aruna. Like, my understanding of the current system is that the appointments are scheduled through a central scheduling service. So in this case, does your model eliminate that and go directly to the doctor for an appointment?
Yeah, it actually does. So what happens is that the doctor will have their own like home page where they will receive a notification from the patient where the doctor can accept it and they will be scheduled. The payment will go through the app, but it will go straight towards the doctor.
Do you think the doctors would want to do that? Do you think you can drive adoption there?
It would be helpful for them because first of all, they wouldn't need to wait for patients because the patients could most likely be accessible anywhere. And second of all, it's all online, so it could even help in the COVID times right now.
So you've said physician several times. Are there other providers as well that you would imagine participating?
Yes, so other businesses, maybe hospitals, maybe like Kaiser Permanente might want to include this because it would help increase the amount of people that are going to them because a lot of the people of color would want to go to these places where they won't really be racially discriminated.
How does payment occur? You said they would pay directly through the app. How does that work with insurance or Medicare or Medicaid?
I'll pass this one off to Shlok Kulkarni.
So we're not actually going to be using insurance because we're essentially like the middlemen, and we're going to be taking an 8% cut from the money that the patient is paying, but it'll be sort of like the payment goes directly towards the doctor and the patient just pays it directly towards it. And we just take an 8% cut from it.
Yeah, so it's basically an online transaction.
Yeah.
Thank you, team. That is all the time we have. Give the judges a moment to finish their forms.
Judges, this was team B018. Let us know when you're ready.
Ready.
Confirm, was that team 18 or 08? Because I saw both of them, I think.
Should be 018.
018, thank you.
I'm ready.
Ready.
All right. So with that, we will move on to our final presentation, which is Team B26, which is Health Now. So team, whenever you are ready, feel free to take it away.
Alrighty. The combination of poor food choices and little access to healthy alternatives resulted in my obesity, which started at 5 years old. It wasn't until I was 20 years old that I decided to change my eating habits and remove myself from the obese category. So, what if we spark this lifestyle change amongst my community? Next slide. Memphis is about 62% African American, and the average household income is $19,000 a year. 35,000 residents in South Memphis are living on an average of 69 years. That is 9 years younger than the average American. 1 in every 3 adults has diabetes, and children make up 25% of the obese population. The root cause of this issue can be healed through dietary habits. Next slide. Our solution is the power of social media. Social media ignited an organization that started by a 17-year-old named Greta Thunberg. This sparked a national movement with passion and social media. Engaging the younger community of Memphis in a fun and impactful way will help implement a social media movement encouraging healthy eating habits. This will influence and impact the lifestyle changes of their communities. The program will be utilized virtually and physically. Next slide. Next slide. And for our business plan, the name Health Now stands for Nutrition Operation for Wellness. This will reach out to Memphis school systems and partner with food banks, the Memphis Grizzlies, and local influencers to fund the program that promotes education and food sustainability and immersive experiences through community gardens. Utilizing college volunteers to mentor high school students through the program will alleviate any financial strain. Next slide. Lastly, our driving motivation is I hear and I forget. I see and I remember. I do and I understand. With our MIT Hack team, including 3 high school students, we conclude that this learning manner will affect change immensely. That's it. Thank you.
All right, thank you all. Now we'll open it up to some questions and feedback.
Hi, it's Maya. What is the specific app or solution that you would be selling, and who's paying for it?
It'll be a program, and it'll be a nonprofit organization. It will be connecting college students to high school students for mentorship and asking to partner with local influencers and food banks to provide food and seeds to begin gardens.
But how would you be coordinating that? I'm sorry, this is Aruna. Like, would you be using a technology to coordinate that, or is it not using a technology?
Our team would be directly communicating with the organizations, and the social media aspect will be basically using the volunteers to post on their social media, and they'll gain like volunteer hours per hour for advocating and advertising the health initiative.
And just to ask this a different way, so the funding is coming from nonprofits that are going to fuel this?
Not necessarily nonprofits. It would be coming from organizations and donations from food banks, reaching out to the Memphis Grizzlies and local influencers and artists.
So one of the things that I would really encourage this team to think about, I think that this is a really important and meaty problem. And in all of my 10 years of experience building technologies to influence health behaviors, I think the theme of gamification and forming teams for engagement and for accountability can go a huge way. So I would encourage you to think about how to incorporate that into your viral model.
Okay.